what we want to do is an overview of the main financial drivers relative to the personal injury case. And we talked about specifically, when we say financial drivers, they're essentially forms of documentation that compensate the patient. And that's really what the AMA guides are about. The AMA guides were developed to take an injury and apply financial compensation to an injury. That's the purpose of the financial guides. It was to transfer a clinical injury to a number for financial compensation. That's the purpose of the AMA guides to impairment. Now, when we talk about the financial drivers, those are the factors that create more or less value within a case. So you just need to be aware of what these factors are to make sure you document them. So again, we're not talking about creating false drivers. That's not what we're talking about at all. But if you don't even know the drivers, chances are you won't even document them. Now you're going to hurt your patient's case and the attorneys also. So you won't be fulfilling your function as a good doctor in lack of documentation if you're ignorant of the drivers. So we do want to make sure that we document as much as possible to the extent possible the injury and specifically the driver. So when we talk about the financial drivers, and the short story of this is back in the 90s, Allstate came up with a program called Colossus. And all it was a software program, and it was a database of the normal injuries. Now, abnormal injuries don't fall into financial drivers. There's not enough data for very unique and unusual injuries, like maybe a burning of the face or something like that, relative to that individual. That case stands on its own. So this is for the standard, because there's a accumulation of database. So all they did is they created a software program to automate all this, and obviously it was used to save money. And so there was about 70% of the insurance companies will use a Colossus or Colossus type program. And then it really is the input. So the data that goes into this software program is essentially taken from the doctor's files. So if it's not in the doctor's notes, the consultation, examination, SOAP notes, re-exams, indexes, narrative reports, if it's not in those notes, it doesn't go in the file, and so you will lose possible documentation for the patient. So most of the insurances adhered to and started using Colossus or Colossus type software. It saved them millions and millions of dollars. And so they just kind of streamlined the standard personal injury case, the whiplash case or the accident injury case, and those injuries. So we talk about the 4 major injuries, and this was from the Insurance Research Council, and we talked about the soft tissue injury is 87% of all the injuries, the soft tissue injury, and the disc injury is 32%, and then the neuropathy 16%, and the concussion is 10%. And so any injury past that is less than 10%. So when you're dealing with personal injury, that's essentially what you're dealing with. Those are in fact your injuries, your injury categories. Now, when we look at the 5 main financial drivers, and the most important of the drivers are injury drivers. So you want to make sure first you document all the injuries, and all the injuries have separate diagnoses. So you may have 6, 8, 10, 12 different diagnoses, and you probably will, and you probably should have. And so each of the injuries should be separate with a separate diagnosis. And then you get into signs, and after that is signs and symptoms diagnosis. But the injuries are the major drivers, and the injuries that I just talked about are the major injuries. So you want to make sure that that's fully documented to the extent possible. So when we look at the different drivers, the number 1 driver is the injury, and then so what are the 4 major? We talked about the 5 major financial drivers. So let's go into that relative to each of the 4 major injuries. So if we talk about we talked about number 1, the injuries, the 4 major. So injury is number 1 of the 5 major drivers. Injury, that's number 1. So make sure you have your multiple separate injury diagnoses. Okay. And then after that, your signs or symptoms. Okay. And now, when 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 we talk about, and we're going to come back to, well, let's do that right now. Let's say um, when you talk about concussion, and we'll go backwards because we'll have to spend a little more time on ALMSI. So if we talk about concussion, which is only 10%, that can give up to a 6% impairment right away. And a concussion is recognized by the AMA guides as even if the person blacks out temporarily upon impact, because you're not going to black out normally. You have to have some kind of brain bruise. We're talking about mild concussions. That's what they essentially are, bruising of the brain. So you want to be sure and you ask if there was any blacking out, dizziness, blurred vision, blacking out right after the impact or upon impact. That's a sign symptom of a mild concussion. So you would document that. That's worth 6% at a baseline. Now, I would also get a consultative analysis from a neurologist, and that should be part of your team, somebody that can evaluate concussions. And the reason you want to do that, and preferably the medical doctor, is for credibility. And also when you have other people that are giving input into your case, it also gives credibility to your case when there's multiple sources. So you definitely want a team. So if you suspect any mild concussion, send them out for a consultative analysis. You don't have to send them out for any treatment. Just send them out for a consultative analysis for that very specific specialty. Now, number two is coming up the ladder here is the neuropathy. And the neuropathy can give up to, again, 6%, even up to 9% per nerve. That's per nerve. And in the latest addition to the AMA guides, that also has to be documented by electrodiagnostics. Now, this is NCVs, EMGs. These are not surface. These are not surface EMGs. These are needle EMGs, NCVs. So to be able to give a neurological impairment or to quantify the injury, you need an electrodiagnostic study, you need the NCV EMG. So if there are any signs of radiculopathy, neuropathy, radiating pain, then I would suggest also doing the exact same thing, referring them to a neurologist to get a consultative analysis. Again, you're not necessarily sending them for care or treatment. You want this doctor's opinion and possible testing. Okay? So, and that helps support your documentation. So, and remember, that's only about 16% of the injuries. So most personal injuries won't have a neuropathy. So coming up the ladder to the disc, and we definitely want to have the MRI for the disc, preferably a type of stress MRI, where it's accentuated. And then also you'll have the medical doctor, radiologist report. And so he's part of your team. And so you should be aware of which MRI centers and which radiologists can appreciate soft tissue injuries and will document those likewise on MRIs. So that just takes a little bit of networking with colleagues, etc., to see who is doing that. And also, I always recommend always meet with these doctors. And I explained this in a separate video, how to qualify your medical team. There's 3 specific questions that you should have answered. So that's the radiologist for maybe a disc type of injury. Remember, that's only 32% of the injury. So, you know, by far, the vast majority of injuries do not have a disc injury or a neuropathy or a concussion. They have a soft tissue injury. So that takes us to the category of, and again, we're talking about spinal injuries of ALMSI, alteration of motion segment integrity, or altered intersegmental mobility. And the only difference is one is just the precursor to the other. And so if you have an injury, an example would be in the spine. If you have an injury, a ligamentous injury in the spine, and all we do is we take, you don't need digital motion x-ray, however digital motion x-ray is nice, But all you need to do is take a flexion extension view, a stress view. That's what you need to do is take a stress view. And those you can either yourself write on their lines of mensuration, and all we're looking for is a translation in the vertebra or a hyperangulation. And so we just document those. And so typically, the typical chiropractor will do a flexion extension stressed view, and then shoot a digital picture of the X-ray. And in other words, you're now digitizing the X-ray. And then you would send them off to a company. There are several companies that will take your digital X-rays, and then what they do is they'll mark line, they'll mark dots, mark dots on certain anatomical aspects of each of the vertebrae. And then the software will measure the angulation of those vertebrae and compare them with normals. So it's a very objective analysis of dynamic study, of a dynamic motion study. So remember, you also have static motion. You got the static pictures, which would be important, but more importantly is the motion, the dynamic study. So simply said, if in the cervical region movements and translations and angulations are different from the low back, and depending on where in the low back you are, and all the numbers are right there in the AMA guides. What is considered normal or abnormal for AMSI? Alteration of motion segment integrity. It does give up to a 25% impairment rating. So it's a very, you got to remember, we're talking about the spine. We're talking about the stability of a spine, and that's why it gives such an impairment rating. And so remember, when we talk about AMSI, we're talking about either a translation or an angulation. And I just want to point out to you that the AMA guide starts at a certain number. So in angulation, it might be more than 11 degrees in certain areas of the neck, or more than a 3.5 translation. And so you wouldn't qualify it until it actually said that, until it actually was more than one of those angles. But again, I want to emphasize that maybe only 30% of your patients might have that. Not all of your patients will have the soft tissue AOMSI. That is not the normal finding, although it's a finding. But you certainly want to be aware of how this works, because this is the vast majority of the injury, number one. It's mostly undocumented, number two. Number three, it's a chiropractic injury. It deals with active, passive, and joint range of motion, and chiropractors are the only providers that deal with all three ranges of motion in the repair phase of healing. So it's a highly specific, not just from a clinical standpoint, but we use that knowledge and material for positioning ourselves for marketing purposes. So if there's translation that maybe exceeds 1 millimeter but does not go past 3.5 millimeters, well, it doesn't qualify as AOMSI, but it does qualify as alteration of motions, altered intersegmental mobility. Well, that's essentially the precursor to AOMSI. And because it's called the guides, they're not rules, they're called guides. So I would just call it altered intersegmental mobility, and then back down on the impairment. So if the impairment at 3.5 is 25%, and let's say I'm maybe at 2, I'm maybe half that distance, then I can easily justify as a professional, or let's say half the distance from 1 to 3.5 would be 1.25 would be half the distance. So if it was 2.25 would be half the distance. So if it was a 2.25, it wouldn't be a 3.5, but so it'd be altered intersegmental function, altered intersegmental function. And then I would, if it was close to half, then I would call it 12 or 13% whole impairment ability. And that's how I justified a 12 or 13% whole body impairment. That's the logic of guides. And if it's less than 1 millimeter, then no research is documenting that at all. But Dr. White of Panjabi and White of Biomechanics of the Spine specifically even states that it's clinically significant if it's over 1 millimeter in the neck translation. Now, that is important to understand what I just said, the difference here, because now we just increased the number of people instead of maybe 30% that have ALMSI. Now we're up to 80 or 90% of the people who do have an injury, but it's not the magnitude of ALMSI. And they'll still qualify under the category, but not ALMSI. Now it's altered intersegmental mobility. But I can still very easily correlate an impairment with that because it's called guides, not rules. They're professional opinions. And if I just do a proportion, if it was half, I would just give half. If it was 1/4, I would just give 1/4 the impairment. And that's the logic of how I would present my case, whether it's in a narrative report or in a deposition or in the court of law. So that is very important. So, and I recommend you do send those out initially. And down the road, you can even buy the software. If you're doing probably 3 or more personal injury cases a month, then you can just buy the software, and you can easily have your staff member trained to put the dots on, take a digital x-ray and put the dots on the x-ray and hit start for the report. It's a lay administrative function. The mechanics of actually doing it, it's a lay administrative function. A high school person, somebody didn't graduate from high school, you can teach them how to do it. So it's not something you, the doctor, would want to do. You'd want to know how to do it and why it's done. But this is a very easy function. So that's what I would recommend in the beginning, is you definitely send it off. Just also read it so you get familiar with the reports and all that. So I wanted to be clear, and that's the difference between ALMSI versus alteration of motion segment integrity. All right, so hopefully we've talked about that and the documentation. So now we have objective documentation of these injuries. Now, in all likelihood, because of the percentages of cases, you're not going to have an MRI, a positive MRI, or a positive concussion, or a positive neuropathy. But in all likelihood, you will have a positive alteration of motion segment, altered intersegmental motion. So let's go. So those were the injuries. That's the documentation of the injuries. Those are the core injuries. And of course, you would just add any residuals accordingly that they may or may not have. So that's the injury drivers. Remember, there's 5 drivers, so that's the injury drivers. Now, the impairment ratings. Now, a couple statements about impairments. Remember that what's the difference of an impairment? What's the definition of an impairment? So there's a difference between an impairment and a disability. An impairment is the lack of human functional capacity. In other words, it's tied to the person's activities of daily living, essentially. In other words, what they do in their life. A disability is a function of work, and those are two totally different dynamics. And a simple example is if I was working, if I was a professional orchestra pianist, and let's say that was one person, and the other person was say a bricklayer, and in both situations I was in an accident that cut off my pinky. Well, how would so what would be the impairment rating for the organist? Well, it would be very low. What would be the impairment rating for the bricklayer? It'd be the same. It'd be very low. How is this inhibiting their activities of daily living? Bathing, showering, dressing, their functional capacity. Well, when you lose the tip of your pinky, it's not that grand. You lose your thumb, that's a whole other issue, but the tip of your pinky, that's not going to be a big impairment. Now, how does it relate to a disability? Well, how's this going to affect each person at work? Well, this now becomes a huge disability for a professional orchestra pianist. They pretty much have lost it. How does this affect the bricklayer? hasn't created any disability in the bricklayer at all. So in the bricklayer, I got no disability, and in the professional organic person, I've got a huge disability. That's the difference between disability and impairment. So be aware of that. Also, impairments are physician functions. Physicians write out impairments. Disabilities are administrator functions. You don't have to be a physician to essentially write a disability. And that's often confused. Many times administrators, like Social Security, etc., will ask you for a disability, and they're not really wanting a disability. They're wanting an impairment. So there's a lot of confusion with those two. So just remember, a disability is relative to work. An impairment is relative to the individual's functional capacity, etc. Okay. So having said that, that's what the AMA guides are. Now remember, we're talking about the second financial driver. So the second financial driver is impairments. So that's a little bit about impairments. Now, we talked about each of the impairments relative to these injuries. So if you can document them accordingly, the concussion, you can immediately get up to 6%, the neuropathy up to 6%. And this is whole body. And then if you the disc, you can get up to 6%, and everything goes up from there with residuals, etc. And then ALMSI in the neck, you can get up to 25%. So this is the impairment function. You just need to be aware of one thing with impairments, that many attorneys are not familiar with impairments, and they are confused. Even personal injury attorneys are confused with a disability versus an impairment. So you do need to know this. And many attorneys won't necessarily want an impairment rating. And the reason they don't is sometimes they'll feel, because remember, the impairment rating is a number that is tied to a financial number. Okay, so they take that formula, they take that number and put it into the formula to give a financial number. And so the attorneys sometimes feel that the impairment will limit what they can ask for in the case. So that's why. So that's why you need to be asking your attorneys you're working with, do you want an impairment rating? Sometimes they do not want an impairment rating because of what I just told you. But I'll just tell you this, most of the time, they don't know what an impairment rating is and the value of an impairment rating, number one. So take that to the bank. That's the truth. 9 out of 10 attorneys you'll deal with don't know what an impairment rating or the value of an impairment rating. And then also be aware that when you do an impairment rating, you want to have it requested that there's an impairment rating. And then just reference it to the guides. That's all you would do, is just reference it to the page in the guides. And that's how you would give your opinion. But be aware that many times the attorneys do not want the impairment rating. Now, at the same token, they're not aware of how much tremendous value there is in AOMSI or altered intersegmental motion. They're not aware, first of all, they're usually not even aware of that injury, that soft tissue injury. So typically when they get a case that's a soft tissue injury with no disc and no nerve, I mean, they don't know what to do with it. So there's tremendous opportunity with all of these cases sitting on these attorneys' desks. They don't have it. They don't have any documentation for any financial drivers, essentially, and they settle for pennies on the dollar with the insurance company. So there's a ton of tremendous potential with the soft tissue injury alone with these cases. But you have to know how to market it. You have to know how to sell it because they're not aware of it. So, and that's a totally different video when I go into how to sell this information and knowledge to create need and a demand. So just be aware that a lot of attorneys are not familiar with impairment ratings. Okay. And then the last component of that was they're not aware of the magnitude of AOMSI or a modified AMSI, which is altered intersegmental mobility. And I'll just call that the modified AMSI. So they're not aware that they could get on these soft tissue injuries 12% whole body, 25% whole body. They're not aware of this at all. And now that becomes tremendous value when you actually share with them and show them how that works. Now, the third financial driver is the loss of enjoyment of lifetime activities, and those are that's an index. Excuse me. That's a impairment function. That's not an index like oswestry or neck disability. Those are functional capacity indexes. Loss of enjoyment of lifetime activities and duties under duress are not indexes. In other words, they're not given during regular re-exams and all that. They're impairment. They support impairments is what they do. And so they're given at the end of the case. They're not given periodically throughout the case to show restrictions or permanent restrictions or limitations. That's what duties under duress, loss of lifetime enjoyment are for. Now, duties under duress are essentially the personal functions of you, and duties under duress are more work oriented. So lifetime of enjoyment activities are related to you as a person. Duties under duress, which is the fourth financial major driver, is more of a work capacity type function. We'll go into those separately also in the individual amount. But here's what we need to know about those. Number one is what I just said. One is that they're impairment functions, not indexes. Now, here's the main thing that you have to be aware of with when you have the patient fill out at the end of care. They fill it out at the end of care. In other words, when they're at what's called MMI, maximum medical improvement. And remember, we defined maximum medical improvement as no further subjective or objective improvement over a 12-month period. And that's tied directly into the 3 phases of healing. Now, does that mean you can't give an MMI prior to 12 months? No, it does not. So when you give an MMI, a maximum medical impairment rating, that's your opinion. And obviously, the closer you are toward the end, the better. If you try to give it toward the very beginning, you're going to not have a lot of credibility. And so we never want to give them MMI in phase 1 or phase 2 of healing. The inflammatory phase or the repair phase, because the body's still progressing and healing. So I typically will only give it in the remodel phase, and I'll only give it after, say, 2 re-exams, and they're in the remodel phase. So I'll go through at least 2 re-exams with no improvement subjectively or objectively. That's the bare minimum of how I would justify giving MMI, maximum medical improvement, or an impairment rating. Because I already know I'm in the 3rd phase, and in other words, I already know there's no more synthesis of collagen, etc. And we've already, and also I'm going to tie that to a therapeutic protocol, making sure they were getting treatments, and there was no progression in symptomatology, a subjective or objective capacity. So you can still give the MMI, still give the impairment when it's not per definition. Remember, these are guides. Now, also, your state can vary. Your state may call MMI at 6 months. They typically do tie it to the AMA guides, and I just shared with you what the AMA guides bases it on. But your state may, and your state basically, those guides, your personal injury guides, will typically fall under your workers' compensation guides. So whatever the workers' compensation guide is for MMI and impairment, typically that's what your state will use for your personal injury likewise. Now, what is so important, now we're talking about the financial drivers. Now, what is so important about the loss of enjoyment of lifetime activities and duties under duress is you have to be highly aware. Number one, they're impairment indexes, but you have to be highly aware of the 3 phases of healing and the 3 ranges of motion and how it relates to the loss of lifetime enjoyment activities or duties under duress. And here's what I mean. When somebody injures themselves and they start getting care and they start getting better, remember, most people, if they have pain, most people won't have too much trouble with active range of motion. In the beginning they will, and it'll just be pain-based, not from muscle weakness. And then as they progress and get better, their active range of motion will kind of get back to normal. Now, what typically does not get back to normal is overpressure and joint motion. That's typically where the pain is. And it has to do with the 3 ranges of motion and the 3 phases of healing. and the hypersensitivity and restrictions of collagen. So you have to be highly aware of how to communicate this and perform. Number one, do it with the patient, and then how to apply it with the patient, and then also how to explain it, whether it's in a narrative report or to an attorney. In other words, most of the time, if you don't know this, you'll have negative or no positive results with loss of enjoyment activity or duties under duress. And it's not because it's negative, it's because you did it wrong. And the reason you did it wrong is because you typically didn't go into the subconscious of the patient's mind, number one. And number two is you didn't go into overpressure with the examinations, because that's where the residuals are. They're not in the active range of motion. Typically, they're in overpressure and joint motion. Now, remember, when a patient, or you, if you were to injure yourself, the first thing you would do is stop that activity. You would limit yourself from doing that activity. Well, that's what patients do. They limit themselves from doing that activity. So remember, 6 months later, when they're filling out the loss of enjoyment of lifetime activities and it says you have any restrictions of doing this or that, remember 6 months ago, or however many months ago this injury started, and they limited. Maybe they don't get out of bed this way, they kind of get out of bed this way, and now they've done it for 3 months, 4 months. So they forgot about it. They forgot how they modified their behavior in getting in and out of a car, sleeping, getting up and down from a chair. So you have to interrogate them specifically in these activities, because a lot of times I found they'll forget them. And so here's typically what happens. They not only will modify their behavior to not have the pain and forget them, but then they'll periodically be taking the NSAIDs, the non-steroid anti-inflammatories, the muscle relaxers, and all that. So between taking muscle relaxers, pain pills, NSAIDs, etc., and modifying the behavior, that restriction or limitation in overpressure of that activity is long gone. And so if you don't do that, and you just hand them the form and say, fill that out, and it says, do you have trouble doing restriction or trouble doing this? They'll go, no, 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 no. And you will not have a true documentation of the restriction of loss of enjoyment of life or duties under duress. And remember, those are very important those are very important from the financial driver aspect. That the loss of enjoyment of duty of lifetime activities is the third major financial driver. Duty under duress is number 4. So these are major financial drivers, and all of these sheets are very specific and personal to what the person can do in their life with their activities of daily living and in their job. So it's about life. It's about human life. So they are very valuable. So you can see how quickly now we can ruin a case. Let's say you did not document AOMSI or altered intersegmental motion. Let's say you didn't document it. Then you didn't know, because you didn't document it, you don't have an impairment rating. And then you didn't do loss of enjoyment of lifetime activities or duties under duress. Or if you did, you just handed the form and said, give it back to me, and you didn't pay attention to taking them past their consciousness and driving it further and interrogating them on all the restrictions or limitations. And if that's how you did your personal injury case, you've just lost 4 of the top financial drivers. In other words, you haven't contributed to that patient or that attorney's case at all in supporting that case. You're worthless. Your value from a financial aspect is worthless up to this point. Now, it may be clinically because you treated the patient and you got paid, but you're not helping the patient or the attorney. You're hurting them, as a matter of fact. So you need to be highly aware of this. And remember, we're talking about the majority of the cases here. So are the majority of the cases going to have a restriction or limitation in active range of motion at the end in their third phase of healing? No. It will be an overpressure with specific angulations and movements, and typically they stopped doing that months ago, combined with taking NSAIDs or anti-inflammatories. And so you have to be highly aware to interrogate them when you're doing the loss of enjoyment of lifetime activities and duties under duress. That is very point specific. Now, that's the third and fourth financial driver. So if you did it right, we're 4 for 4 now. We have an impairment, we have a we have a soft tissue injury. We either have altered intersegmental motion or AMSI. Chances are it's probably altered intersegmental motion, more so than AMSI. But we have a valid, imperable, rateable injury, and it's probably, if it was halfway, we're at 12% whole body. Compare that to what you had by not doing it. And then, so we got the injury. It's objectively documented because we've got what's called computerized radiographic mensuration analysis. That's that computer that you just put you put mark dots on the X-ray and it measures the lines of angulation. That's called computerized radiographic mensuration analysis. So we have third-party objective evidence of the aberration, number one. Number two, we have third-party documentation saying this is an impairment called the AMA guides, number two. Number three, you will have some type of overpressure restriction or limitation in range of motion with the duties on lifetime enjoyment activities or duties under duress. I'm 4 for 4 right now. I've got all 4 financial drivers covered. And then the fifth one is the prognosis. And remember, a key component of the prognosis is number one, stating the correlation that this accident caused this injury, number one. Remember, there's 3 components to the prognosis. Number 2 is the therapeutic protocol. Well, that's where your indexes come in. Your treatment protocol, what you did, why you did it, based on the response of the patient and the 3 phases of healing. That supports why you did what you did therapeutically. And then you have that documented in your initial consultation and examination. You have it documented in your re-exams, and you have it documented in your indexes. So this is where the neck disability index or the low back, the Oswestry index, this is where you want to use those indexes is per re-exam. So that's the documentation showing the response to the therapeutic protocol. And so you would make comments not only supporting what you did, how they progressed, and why you used, what therapy you used, or what treatment protocol, combined with the 3 phases of healing, and then also their response to treatment. So you have it totally documented. And then the third category is future care. And remember, after the injury, future care is a huge financial driver. So an injury is a financial driver, a major financial driver. What injury is it? As well as future care, because future care is compensatable. So if it's a younger person and they put into an actuarial scale that younger person and how much treatment they're going to need to the rest of their life, that leads to a large sum of money. So that's very important that you have the ability to explain future care. And we talked about future care is and permanency based on the 3 phases. So you should be able to explain permanency based on the therapeutic response. You have it documented. How it relates to the 3 phases of healing. We know physiologically there's no more synthesis after the repair phase. And then maybe they've plateaued in the remodel phase. They've plateaued with their therapeutic approach. And now we've gone at least 2 re-exams where there's no improvement in symptomatology or functional capacity. And there you go. Now we took a case that was dead, sitting on the attorney's desk that was totally dead, and we've documented the soft tissue injury. We've documented it and correlated objectively. We documented and correlated with the AMA guides, and we've documented it with the loss of enjoyment of lifetime activities and duties under duress. And we are able to explain from a physiological, scientific standpoint and why those were positive and restrictions with pain, whatever those were that the patient had. And then we were able to correlate with their history, the cause and effect, this accident caused this and why. And then we were able to associate the therapeutic response to care and the stabilization, that there's no more improvement, and explain why. And then future care. And we explain future care would be based on the care that you would look backwards to find future care. What care did they need when they stabilized for a palliative effect? In other words, once they're past the 3 phases and the proactive treatment, and now it's just a palliative approach. How can we help them? Symptomatology. Well, they should have been on that treatment schedule, preferably for 2 months on a palliative treatment schedule that between both of you figured out what was best for them, whether it was once a month treatment, twice a week, once a week, whatever. and what type of therapy worked best for them. So now you have a total personal documentation of why they need that care going forward, because that's the care that they've showed and established going backwards. That's the financial driver. So in summary, look how we put this case together. This was the soft tissue case sitting on the attorney's desk that was essentially worthless. They didn't, let's say they didn't have a concussion, they didn't have a neuropathy, and they didn't have a disc. Now, by the way, remember, if they did have a disc lesion and they did have a neuropathy or a mild concussion, what's the chances that they had that injury in addition to the soft tissue injury? See, now it even gets compounded and magnified. It's pretty rare to not have a soft tissue injury but have a disc lesion or a neuropathy. It's very, very unlikely and unusual. But most of the cases don't have those. So you have this soft tissue injury. The attorney doesn't know what to do with it. They don't have doctors that know how to document it. And you come in, and now you know how to document, you know how to objectively document the soft tissue injury. You know how to tie it to an impairment. You know how the meaning of loss of enjoyment activities and how to apply it. You know the meaning of duties under duress and how to apply it relative to the physiological facts of the 3 phases of healing, specifically as it's relating to the 3 ranges of motion, pointedly over pressure and joint motion with that person's personal activity. And then going right into the prognosis, cause and effect, therapeutic protocol, stabilization, 3rd phase of healing. I have the impairment. I justified MMI, and I easily can project future care. I just created one heck of a case for this attorney, more importantly, my patient. And that's good documentation and progression of the case. So I just wanted to cover the main financial drivers. And of course, we're going to take this information and turn it into marketing. We're going to turn it into what's valuable to get business, so we can perform these activities and support our patients and support the attorney for what they're trying to do with the patient likewise.